on ocular surface tumors, and I'll be talking about the congenital tumors of the ocular surface and few other non-epithelial tumors. So these are mainly the list of the common things that we see in the ocular surface other than the epithelial tumors and OSSN, which of course remains the major chunk. And I'll try to cover some of them as a case-based scenarios. So epibulbar choriostomas are possibly the second most common ocular surface lesions that we see after the epithelial lesions and the OSSN. And based on the content of this lesion, they can be either a simple or a complex choriostoma, depending on which germ layer the contents are arising from. If it's from a single germ layer, then these are classified as simple ones where there is one type of tissue. And if it is more than one type of tissue, it is classified as the complex choriostomas. So dermolipoma is something which is pretty commonly seen, and this usually the location is in the temporal phoneal conjunctiva. Sometimes there can be syndromic association, most commonly with the golden house syndrome with associated preauricular skin tags. And most of the time they are present since birth, but generally tends to get manifested over a period of time. So it's the teenage or the young adults who will come to you, and generally the concern here is cosmetic purpose, because when the patient tends to look medially, this lesion tends to become visible. So the indication for removal here is mostly for cosmetic purpose, and sometimes there are very fine hair on the surface of the lesion, and even the conjunctival epithelium can get very much keratinized, which can cause irritation on the ocular surface, and that could be another indication where this lesion tends to be removed. What is important to realize here that whenever we are trying to remove a dermolipoma, never chase and try to excise the complete lesion, because invariably part of it, the content are mostly fat, that's why they look yellowish, and invariably part of it is going to go inside the orbit and will have extension around the lateral rectus insertion, sometimes around the sheath of the extraocular muscles. And since they're not well-defined lesion, if you try and go for a complete excision, you will end up causing scarring in that area around the sheath of the muscle, and if that happens, the patient will end up with diplopia, restriction of the ocular movements. So that is something which should be avoided. Our idea is only to excise or debulk rather the part which is visible when the patient is looking medially. So what you do, you mark out the area which is visible when the patient is trying to look medially or in the primary gaze, and that's the area we try to excise, and we don't kind of pull the lesion out from the orbit and try to debulk more of it. And since part of it could be adherent to the conjunctiva, usually part of the conjunctiva needs to be sacrificed, especially the central part, and in that case, if there is a loss of conjunctiva, we can put an amniotic membrane grafting and try to cover the defect. Otherwise, if it's a small defect in a small lesion, we can do a direct closure of the conjunctiva also. Important thing here is to differentiate it from orbital fat prolapse, especially in little older patients. Fat prolapse is pretty common, especially in obese patients who have thyroid eye disease or have laxity of the eyelids, and it tends to be mostly in the lateral fornix, sometimes can be in the other part also, and usually their subconjunctival lesion will be freely mobile, and the conjunctiva will be separate from the lesion, will be more yellowish, is not going to present since birth. We don't see any hair on the surface of these lesions, and so a good history and can help us to differentiate a dermolipoma from an orbital fat prolapse. Epibulbar dermoids again are pretty common, mostly seen in the limbus, so it could be a limbal dermoid or sometimes can involve the predominantly cornea, just like what we see in the first patient where there is mostly a corneal involvement, but more often than not it will be involving the limbus. In long-standing cases, because of exudation from the blood vessels, which are there usually in the lesion, you can see an arc of lipid deposition into the cornea. And this is something which is going to tell us that we are dealing with a chronic long-standing lesion. And why is it important? Because many a time these lesions, especially if they're inflamed, tend to be masquerading other non-benign or neoplastic sort of condition, can be sort of confused with them. So sometimes dermoid can have surface here because the contents are usually appendages, epithelium, as well as the appendages of the epithelium. So sometimes you can have hair follicles coming from the surface. It's a keratinized epithelium, and this is what sometimes causes ocular surface irritation, watering, and if that is the case, there is an indication for removal of the dermoid. So just to emphasize, we are talking about inflammation. Rarely the dermoid can get inflamed, but if you see here, there is this white arc of lipid deposition at the leading edge towards the cornea, and this is what tells us that it's a long-standing lesion and this is not something which is neoplastic, though there is a lot of inflammation, some dilated feeder vessel-like sort of, look also which is there. But these are again limbal dermoids. So really they can be inflamed also, especially in young adults. So mostly excision is usually for cosmetic purpose, if it is obscuring the visual axis coming over the cornea. So that's the time we can remove it. Sorry, I think I'll skip the video. Otherwise, sometimes if there is a very high astigmatism because of that, that could be one of the indication, but most of the studies have found that the scar which is left behind after the removal also tends to cause equal amount of corneal irregularity, and there might not be too much of difference in the astigmatism or the improvement in the vision. But if you are planning to put a contact lens and if the lesion is too high, you can debulk part of it. It's important if you are planning a debulking of the dermoid to assess the depth of the invasion. Really, dermoids can be intraocular, can extend throughout the cornea. Most of the time they will be limited before the Descemet's membrane, but rarely there can be extension beyond the Descemet's and sometimes involvement of the angle and the intraocular extension also. So in that case, a full thickness excision is required, and then we have to be prepared to cover the defect with a corneal or a scleral or a corneoscleral patch graft. So more often than not, it's a good idea to take help of your cornea colleagues if you're planning an excision of the dermoids. Do a UVM preoperatively, assess the depth of the lesion, and then only we plan an excision. And a counseling of the family before excision that the scar is going to persist after the surgery is very, very important, because most of the time they will come for a cosmetic indication. So what we do is, the video is not playing, but mostly what we do is we debulk the lesion, the superficial extent. We don't try to go deeper if the lesion is not going deeper. And that scar which is there in the cornea, the tattoo is put on that scar, and on top of it an amniotic membrane grafting can be done. And if it's a little lamellar excision of the cornea, you can put a lamellar patch graft also. So that tends to mask the scar, white scar which is visible, and generally this is cosmetically much more acceptable. These are the complex choriostomas, what we call as epibulbar complex choriostomas, because histopath shows tissues from more than one germ layer. Sometimes there can be cartilage, salivary gland, lacrimal gland tissues also, other than the skin and its appendages. And more often than not, they have syndromic association, most commonly with the linear nevus sebaceous syndrome. So this is a patient who has this linear nevus, cutaneous nevus, and we know that this syndrome can have other implication in terms of CNS involvement and other systemic implication. And in adulthood, many a time these areas of cutaneous nevus can develop really malignant changes. So this is something which needs to be recognized, and also the family needs to be counseled accordingly. Rest, the treatment of the choriostoma remains on the same line. If it's a cosmetic concern visible in the palpable aperture, then a debulking of the lesion can be done and the defect can be covered with an amniotic membrane graft if required. So this was one rare case where the choriostoma is actually involving the palpable conjunctiva. More often than not, we see choriostoma on the bulbar conjunctiva, but this one was actually involving the palpable conjunctiva. And this was a complex choriostoma, non-syndromic, and this patient, the main concern was the medial droop, and only on eversion of the eyelid, this was the lesion which was visible. So it's not that all dermoid, epidermoid or choriostomas will be there in the bulbar conjunctiva. Sometimes it can be there in the palpable conjunctiva, and unless and until we recognize, we are aware of it, we might mistake this lesion as something else and try to sort of, the treatment might not be appropriate. This picture is just to highlight that, the color of the choriostoma can sometimes give us a clue as to the content. If it is more of a dermoid, where there are more of epidermal elements, skin and its appendices, mostly they tend to be more yellowish in color because of the fat and the other content. If it is more of lacrimal gland component, which are mostly in the complex choriostomas, it's more reddish and pinkish in color. And if there is cartilage or other tissue, it tends to be more bluish looking color. So it might be just a small clue which might tell us what kind of tissues we might be dealing with, and we can actually try to corroborate with the histopathology. So nevus sebaceous syndrome is one syndromic association which we should look for if your diagnosis is an epibulbar complex choriostoma. Now, moving on to the cystic lesion of the conjunctiva, most often the cystic lesions will be acquired following trauma, following surgery, but sometimes we do see cystic lesions in childhood which tends to be congenital, like in this sort of lesion where the main complaint of the patient remains a drooping of the eyelid, and once the patient looks down, you can see this subtle fullness which shows that we are dealing with a lesion which is not in the orbit but possibly in the preseptal area, and on eversion of the eyelid we see this greenish bluish cystic lesion which is going to be transluminant positive, and this lesion is usually arising or adherent to the upper border of the tarsus. So these are supposed to be implantation cyst because of the when the fornix growth is happening during the developmental phase in utero. Sometimes the conjunctival epithelium can get folded or impinged into the fornicial tissue, and that's how later on in life this cyst tend to develop. And there are several reports of the cyst getting adherent to the superior rectus or the LPS muscle also. And mostly these are excisable lesions, but since the base is going to be adherent to the conjunctiva at the upper border of the tarsus, that's the area where they tend to rupture if we are not careful with the dissection. So it needs a little more patient dissection. And the other option is, if the complete dissection is not possible, we can simply marsupialize the cyst, means that we excise whatever is excisable, whatever remaining epithelium is there at the base of the lesion, we let it go into the fornix. So in a way, it tends to deepen the fornix, and that epithelium becomes part of the conjunctival epithelium at the fornix, which can avoid the fornicial shortening, which otherwise can happen if we tend to excise or sacrifice conjunctiva while excising this lesion. So these are again the implantation cyst, mostly seen in the fornix, but sometimes it can be seen in the other locations also. So this is the poster picture of the same patient. This was post-excision. But really you can have bulbar conjunctival implantation cyst also. This was a young child, in fact, early teenager, in fact. He has this lesion since early childhood, since birth as per the mother, but it has increased in size recently, and that's why they have come, because the cosmesis was a concern, and of course the ocular surface tear film disturbance. And again, these are lesions which are usually epibulbar, but since these are long-standing lesions, they tend to cause pressure effect on the sclera. Sometimes there can be the scleral lamellae can get compacted. There could be localized thinning of the sclera. So it's important again to assess the depth of this lesion by doing an UBM if we are planning a surgical excision of this lesion. Like in this lesion, you can see it's a very broad base which seems to be sitting on the sclera. The scleral lamella have got compressed and compacted in that area. There is thinning. So if you are not careful with the dissection here, we might land up perforating the globe. Same here, this was a slightly younger child. Here we can see the lesion infranasally, and there is a slight bluish tinge which tells us that the sclera probably is pretty much thinned out here, and we are seeing this bluish tinge because of the underlying show of the uveal kind of tissues. So the same is corroborated on the UVM, where we see an extreme thinning of the sclera at least at one point of the center. So here again the idea is either we can go for marsupialization, excise the lesion till here, till at the edges, and whatever is remaining at the base we can either just cryo and leave it there, or if it is possible to separate or scrape off the rest of the epithelium, we tend to do that. Vascular lesions can have varied spectrum. It can be small specks of dilated, tortuous, secular dilatation of the blood vessels. These are mostly the cavernous hemangiomas of the conjunctiva. Not very common, but sometimes we do see, and it's a good idea to do a good ocular evaluation, including the retinal evaluation, to rule out any associated retinal involvement also. Sometimes it can be subconjunctival lesion like this, where they tend to bleed, and that's sometimes the reason why the patient might come to you, recurrent episodes of bleed, though not very common in the cavernous malformation, more in the lymphatic, venolymphatic, but rarely they can bleed. So this was one cavernous hemangioma vascular malformation on histopathology, but the presenting complaint was a bleed, recurrent episodes of bleeding. That's the reason the patient had come. More commonly what we see are the venolymphatic malformation, which can be a combination of various venous or lymphatic vasculature, and generally tend to have an associated orbital component which needs to be ruled out by doing a good examination. If you find any proptosis, it's imperative that we do a good imaging, a contrast enhanced or at least a dynamic contrast imaging to rule out any associated orbital involvement, and also do a clinical evaluation including a Valsalva maneuver. If the Valsalva is positive, that tells us that there probably is more of a venous component, and there is likely to be an orbital deeper component which is going to be there with dilated or maybe big feeder vessels also. So again, the treatment here is either we can go for a sclerotherapy if it's a localized lesion, or if it is isolated, confined to the conjunctiva, surgical excision is also a treatment of choice. This was one patient who was treated with bleomycin. So it's a direct intralesional injection of bleomycin. The concentration varies depending on the size of the lesion, but usually we tend to put it as one international unit. 10 units is the maximum dose you can give, and the dilution based on the amount required you can reconstitute. So the vial comes in about 15 units, so based on that you can use either 5 units or 10 units, whatever is the, depending on the extent of the lesion. It has responded pretty well to just one injection of bleomycin. The third commonest conjunctival lymphatic malformation are the small cystic dilatation, which we call as lymphangiectasia. These are basically the lymphatics, abnormal lymphatics, which tends to have saccular dilatation at places. And mostly the patient will come with a complaint of recurrent episodes of conjunctival chemosis. So many a time this patient gets misdiagnosed as conjunctivochalasis. So if you find a patient who is coming with a recurrent episode of conjunctivochalasis or chemosis of the conjunctiva without any other reason to explain that, it's a good idea to do a good evaluation under slit lamp, look for those small cystic spaces, because we could be dealing with a conjunctival lymphangiectasia. So if that is the case, and if it is happening recurrent symptomatic, then we can go for either a cryo to this lesion, or we can go for excision of the lesions also. Rarely this lesion can get filled up with blood, especially during episodes of URI, because we know that lymphangiomas tends to get aggravated during the episodes of URI, and that's the time they can even bleed also. Reactive lymphoid hyperplasia, which could be a benign counterpart of the lymphoproliferative spectrum of disorders, seen in children and tends to be, or speculated to be, the etiology is supposed to be a chronic antigenic stimulation, probably secondary to some infections like either EBV or sometimes HIV also. And chlamydia infection is again supposed to be one of the predisposing factors for reactive lymphoid hyperplasia, but the data is not foolproof because the incidence of associated chlamydial detection of antigen is variable across the world. But based on this presumption, many a times they tend to be treated with doxycycline also. Otherwise, topical steroid for smaller lesion, asymptomatic lesion, and for a slightly bigger lesion like this, which was visible cosmetically and symptomatic also, we can go for surgical excision, do a good histopathology to confirm the diagnosis, and treat accordingly. Lymphoma is, of course, the malignant counterpart in the spectrum of the lymphoproliferative lesions, and we know the classic color of the salmon pink appearance of the conjunctiva, which is almost diagnostic even before you do a biopsy. So associated orbital component is present more often than not, and it is manifested in the form of a proptosis in a lesion who has a conjunctival pink lesion like this. And this gentleman, in fact, was sent from the cataract clinic because he had come for a cataract surgery, but they felt that the ptosis was obscuring the visual axis and he might not gain much after the cataract surgery. So that's the reason he was sent for correction of the ptosis, but when we everted or just pull the eyelid up, this was what was visible in the fornix. So on spot, looking at the lesion, we knew that it was a conjunctival lymphoma, and it was going beyond the fornix. We couldn't see the posterior extent of the lesion. We got a CT scan done, and you can see the thickening of the superior rectus LPS complex, meaning that the lesion is actually arising from the superior rectus LPS complex, and that was the reason why he was having the ptosis also. So these are mostly depending on the grade of the lymphoma. We do a biopsy, confirm the diagnosis, do a systemic workup to rule out any other systemic involvement, and if there is a systemic involvement, usually the treatment is chemotherapy. If it is an isolated orbital involvement, radiation works pretty well. This is one patient where there was an orbital component, as we can see the imaging, but it manifested as a conjunctival salmon pink lesion. This was treated with radiation because it was a unilateral lesion. Systemic workup was negative, and the response to radiation is pretty good. Rarely other spectrum of the lymphoproliferative, like the T-cell leukemias or lymphomas, acute leukemia, can also present with a conjunctival pink fleshy mass, almost similar to what we see in lymphoma. But this is in a child, so lymphoma does not happen very commonly in the children, especially the NHL, what we commonly see, the B-cell subtype. So in a child like this, acute onset presentation, this was in fact diagnosed as a conjunctival chemosis, treated for some time with conservative treatment before it was referred. On biopsy, it turned out to be a leukemia, and when we did the bone marrow, she had leukemic deposits in the bone marrow also. Otherwise, in such cases, if you're suspecting leukemia, even a peripheral smear sometimes can give you the diagnosis. So what do you think this is the diagnosis in this gentleman? He has these recurrent episodes of irritation, watering from the eye, and all we see is this small fold of conjunctiva, almost like a conjunctival callosis, but localized medially. What do you think it could be? All right. So this is his picture of the lesion. So this again looks like more like a subconjunctival lesion. It's not very pink, it's more, there is a yellowish tinge to it. And many a time these are the lesions which can mimic and subconjunctival extension of extraocular muscle cysticercosis, which is again something which is not very uncommon in our setup. But cysticercosis is not going to be a mobile lesion cyst. It's usually fixed to the episclera, little firm because it is tense cystic, but the color can be sometimes very much like that. But since this was not very firm, not mobile, seemed pretty soft, we decided to go ahead with the biopsy, and it turned out to be a conjunctival myxoma. And so myxoma again we used to think it is pretty uncommon, but it's not so. I think in the last last 6-7 years, we saw about 6-7 patients. And the lesion, the color of the lesion and the appearance is very characteristic. So once we see one, we get the histopath, probably the next lesion we can diagnose even without a histopath. Intraoperative diagnosis is possible because once we take out the lesion, it's very gelatinous, like a jelly. It's not a well-defined lesion. Sometimes they can extend to the orbit also along the extraocular muscle. And important to be aware of something known as Carney's complex, because a conjunctival myxoma rarely can be associated with cardiac myxomas also, and can have associated embolization from the myxoma, and can have other issues like atrial fibrillation and other issues also. So the last bit, this was another elderly lady, acquired ptosis, and she has this yellowish lesion in the fornix conjunctiva, subconjunctival in fact, and there is some thickening of the eyelid also medially. So generally these are the lesions which tends to be kind of, our clinical differential always remains a sebaceous gland carcinoma, especially in this age group. But one of the lesions which we need to be aware of is conjunctival amyloidosis. This again has this appearance, yellowish white, but the surface will be more waxy. The history is going to be chronic. There is not going to be any erosion or ulceration of the surface, but it can cause episodes of recurrent hemorrhage, because amyloidosis we know have blood vessels which are fragile, and it can have recurrent episodes of hemorrhage, especially in the same site. So again, biopsy with the congruent staining can give us a diagnosis in most of the cases, and I think that's all I have on the benign and other lesions. Thank you.
Thank you, Seema, for a very comprehensive coverage. Seema will be leaving for another session, so if you have any questions for her, you can ask now. Thank you. I'll be very briefly covering the rest of the tumors, that is epithelial and melanocytic, which are of course the most common ones of conjunctival tumors, and also dealing with the management. Rest of the instructors have abandoned me for better sessions, I suppose. All right. So why do we know about ocular surface tumors? Because these are most easy to diagnose. You don't need a specialized equipment, you don't need an expensive fundus camera, you don't need angiography, you don't need nothing. You just need a slit lamp evaluation and some knowledge, because what the mind doesn't know, the brain can't see, or otherwise, what eyes can't see. So, and these are most common of ocular surface tumors, most common of all tumors. In fact, if you look at all intraocular tumors, orbital tumors, eyelid tumors, etc., or have a data collection of all the tumors that you can get in the eye, ocular surface tumors comprise of about 50 to 60% of all tumors. So they are most common. But the most important aspect here is that 50% in adults can be malignant, and of these, 20 to 40% have reported local tumor recurrence. That means that if you excise them properly, obviously you'll have no local tumor recurrence or minimal of that. But if you don't excise them, or if you don't follow a protocol-based approach, then you have a very high chance of local tumor recurrence, thus predisposing the patient to regional lymph node metastasis and systemic metastasis, and even loss of vision, loss of an eye, etc. But then if you use a protocol-based management, you can reduce the local tumor recurrence to less than 2%, and that is true. In a busy clinic, you will be inundated with lesions of the conjunctiva, some of which may look like pterygium, some of which may look like pincula, some of which may just look like a cyst. There are many cases that were shown by Seema, which could be very confusing for a clinician who is a general ophthalmologist, or somebody who is a cornea specialist, or a retina specialist, or a cataract surgeon. But in the middle of which would be hidden something very sinister, and that could be a tumor. And how do you identify all that? It's very easy, because each tumor comes with a signature. Each tumor has a very specific clinical feature. If you look at it, you'll be able to identify. And that's how you'll be able to recognize. Seema has covered everything except epithelial and melanocytic, and I'll cover what is left. Now, epithelial tumors can be further classified as squamous epithelial tumors, which are benign, papilloma, hereditary benign intraepithelial disc keratosis, which we will not cover because it does not happen in India. It happens in triracial individuals who are called Navajo Indians in the United States, especially in the North Carolina and South Carolina provinces. Pre-malignant and malignant tumors, ocular surface squamous neoplasia, because it's a encompassing term which includes dysplasia, which is a pre-malignant lesion, carcinoma in situ, and invasive squamous cell carcinoma. And there are other epithelial tumors as well. The diagnosis here is very clear. Why is that? Because you find a papilliform lesion with a central vasculature from which there are blood vessels which are emanating, and there is a bunch of feeder vessels as well. So this is conjunctival papilloma. How do we say it is papilloma? Why not a papilliform ocular surface squamous neoplasia? Because there is no keratin. So if a conjunctival lesion has a papilliform architecture but no keratin at all and has feeder vessels, irrespective of that, your primary clinical diagnosis would be conjunctival papilloma, and you can keep ocular surface squamous neoplasia as a differential diagnosis. And also it is in the area which is not in the interpalpebral vulva conjunctiva, because ocular surface squamous neoplasia is most common in the interpalpebral vulva conjunctiva. This is in the inferior vulva conjunctiva. This is also a papilloma, but this is in the lower eyelid. Somebody has excised a papilloma here, but now this has happened here. Again, you see in the magnified picture, there is a central vessel from which there are radial vasculature. So it looks like this in magnification. There is a central large vessel from which there would be radiating blood vessels. That's a very typical architecture which will not miss on slit lamp evaluation. And there is no keratin. Generally, it does not happen in the interpalpebral vulva location. Generally. It's caused by human papillomavirus type 16, 11, 6, 33 and 45 are also possible. Now, who does it get infected with HPV virus? Anybody can get infected with HPV virus, not just females, males as well. And those who are immunocompromised can get obviously more infected. But the solution to this is now HPV vaccine. With the onset of HPV vaccine and that being available, in fact, a pentavalent vaccine is available against all these strains in India currently, which pubertal girls are being administered. And in fact, immunocompromised individuals can also get the same vaccine. In fact, there are reports in the literature saying that people who are administered this vaccine had a complete remission of papilloma. In fact, even ocular surface squamous neoplasia, which was produced by a pre-existing papilloma induced by HPV-16. So even vaccination can treat some of these patients. That looks like a very aggressive lesion, but that is also a papilloma. You can see a very clear architecture. Now, in a situation like this, we'll get very confused because this is in the interpalpebral vulva location, very aggressive looking lesion. It could be squamous cell carcinoma, but on excision, it turned out to be a papilloma. So papilloma have a spectrum, some of which look like very typical, very benign. Obviously, they live up to what they appear to be, but then some of them look like this, very aggressive, but they tend to be papilloma on excision. But then you can't take a risk. So whenever you have a conjunctival lesion which is appearing borderline, you have to give it due respect and excise with clinically clear margins. Some papillomas can look like this, pigmentation. So pigmentation is only seen in dark-skinned individuals, Asians, and also the South Americans or anybody who has some amount of skin pigmentation, not in Caucasians. Again, you find architecture here, the blood vessel, radiating blood vessels from it, but this part is pigmented. This is not melanoma, this is a papilloma which is intensely pigmented. This was a Mongolian patient who was referred after he was excised 3 times and he had a recurrent lesion. This has the entire ocular surface involved, and not just that, it was in the nasolacrimal duct as well, and through which it was in the nose. So it had a large papilloma. So we could vaporize and excise most of the conjunctival component. We had to do dacrocystectomy and fulgurate the intranasal component and treat the patient with systemic interferon, and that actually settled it. So there is an argument to use interferon in papilloma, and also in the West they use cimetidine and levomazole, which are immunomodulating agents. They boost immunity for a temporary time, and that actually can help resolve papilloma. So that is some of the options, systemic therapeutic options that you have in these patients. This was a child with an aggressive papilloma, thrice excised elsewhere, again recurrent. This We didn't excise at all. This was treated with systemic interferon and the child had complete regression. So in aggressive recurrent papillomas, you can opt for systemic interferon, which your oncologist will help you give. Now, when a papilloma is atypical, then you should worry about it. This patient has a typical papilloma here. This patient is immunocompromised because she has undergone renal transplantation and she is on post-transplantation immunosuppression. This is a typical papilloma on the right eye. In the left lower lid, she has a papilloma which has a broader surface and a much broader base. So this papilloma is looking like this. The surface is ulcerated and a much broader subconjunctival base. So then you should worry because papilloma is inverted here. This is called inverted papilloma and that has a very high chance of having coexisting squamous cell carcinoma transformation. So in an immunocompromised patient, when a papilloma looks broad-based, then it could be squamous cell carcinoma. Well, is this papilloma? It looks like papilloma, but you can see that the patient had a large chalazion which has burst, and that is a subconjunctival extension which ultimately got extended to the bulbar conjunctiva as well. This was just a pyogenic granuloma. I'll skip the Navajo-Indian thing. All right, so we'll go to, right. Yeah, what does this look like? This has a corneal pannus, vascularized one, loss of definition of the limbus, and cornea specialists may call it acquired limbal stem cell deficiency, right? And they miss the tumor that is staring at you. Do you think it is ocular surface squamous neoplasia? Possibly, it could be, right? But your ocular surface examination is never complete until you evert the lid. When you evert the lid, you find that this is the normal lid margin. Here the lid margin is thickened 3 times. This is the normal sharp posterior lid margin which you see on eversion. This posterior lid margin is all destroyed and rounded, and you see no meibomian gland orifices in the lid margin at all. So that immediately makes you suspect that it is actually a sebaceous gland carcinoma, pegytoid variant. So in a sebaceous gland carcinoma, what are lost are meibomian gland orifices because it's a tumor of the meibomian gland. The posterior lid margin gets rounded and the lid margin gets thickened apart from a conjunctival lesion. So this is a pegytoid sebaceous gland carcinoma, does not have a large tumor that you're used to seeing. So any patient with unilateral blepharoconjunctivitis with what looks like an ocular surface tumor, you should suspect pegytoid sebaceous gland carcinoma. Now this looks exactly similar, isn't it? This is a different patient. This is a different patient. Looks exactly similar, but the diagnosis is different. That's because you see white dots here. These dots are nothing but keratin. So whenever a patient has a conjunctival lesion with keratin, that means it is an epithelial cell tumor which a high epithelial cell turnover. Keratin is a byproduct of high epithelial cell turnover, and that is ocular surface squamous neoplasia. So one signature for OSSN is presence of keratin. So whatever may be the tumor, whatever may it look like, but if a tumor has keratin, then you should think of ocular surface squamous neoplasia. This was diagnosed as peripheral ulcerative keratitis. A cornea specialist has done a conjunctival resection, glue BCL for the peripheral corneal gutter. But what was missed here was this patch of keratin. This was squamous cell carcinoma with scleral invasion. So it can present as peripheral ulcerative keratitis. There's one more case here which can also look like peripheral ulcerative keratitis, not to miss the scleral nodule. So these are not immune-mediated peripheral ulcerative keratitis. That corneal gutter is because of tumor infiltration into the cornea and the limbus, and the nodular component is very evident. One more situation which may look like peripheral ulcerative keratitis. So when a patient looks atypical for peripheral ulcerative keratitis with a scleral nodule or keratin, you should suspect OSSN. This looked like a sterile corneal melt to a cornea specialist. He did what he could. He did a patch graft. Very nice patch graft indeed, but when he sent this necrotic material to the pathologist diagnosed ocular surface squamous neoplasia. Why was it missed? Because all this keratin was cleaned out by the fellow before the consultant saw it, and there was exuberant keratin, which already tells you that you're dealing with a corneal melt. It is of course a sterile corneal melt that is induced by tumor infiltration and not because of immune mediated scleritis. I'm the only speaker left, so this is my course, so please don't keep buzzing. At the end of the time, I'll finish. Necrotizing scleritis. This is definitely necrotizing scleritis, but not immunologically mediated necrotizing scleritis, but a tumor-induced necrotizing scleritis. You can see exuberant keratin again. So what I'm trying to stress upon is the fact that keratin is one of the signatures of ocular surface squamous neoplasia, and that will help you diagnose it in atypical situations. The second signature is abnormal vascularity. This patient had undergone a phototherapeutic keratectomy because the cornea specialist thought it was a corneal scar. Actually, it was and it is at the level of the epithelium. You can see that, right? And when you look at it closely, you find abnormal blood vessels here. So this is a ocular surface squamous neoplasia with a predominant corneal epithelial component. The epicenter of the tumor is here, which is much flatter and subtle. So you can miss this subtle tumor, and what looks like on the cornea is a corneal scar or maybe a epithelial issue, related issue. Rolika, can you tell them not to do that? Yeah. So here we have abnormal vascularity, that is a signature of the tumor, and that is ocular surface squamous neoplasia. So these are all the masquerades of ocular surface squamous neoplasia. Each one looks different. When each tumor looks different, how can you be sure of the diagnosis? You can be sure of the diagnosis by looking at 2 or 3 major or important clinical features. One is its interpalpebral bulbar location and its epicenter being the limbus. A limbal lesion which has some amount of extension onto the cornea, some amount of extension onto the sclera with abnormal vascularity and bits of keratin is definitely ocular surface squamous neoplasia. Some of these may not have keratin, but they still carry this abnormal vascularity, feeder vessels and intrinsic vascularity, and they transgress the limbal barrier and go on to the cornea. That is a very typical fleshy appearance of OSSN. Some of them look like papilliform. They look like conjunctival papilloma, but at the same time, you can't miss this corneal epithelial invasion, which does not happen with papilloma. Papilloma can overlap the cornea or hang on to cornea, but it does not infiltrate the corneal epithelium. Any lesion that has a corneal epithelial infiltration, you should consider as ocular surface squamous neoplasia. This is a nodular lesion, very elevated lesion, but you can not miss the limbal location. You can't miss the scleral and the corneal component and the abnormal vascularity. So I'm showing you a bunch of cases which are ocular surface squamous neoplasia, each of which is different, but the commonality here is the location, epicenter being the limbus, corneal epithelial component and the scleral component, abnormal feeder vessels and intrinsic vascularity and keratin. So all these patients have different morphological variants of ocular surface squamous neoplasia. Some of them can be even pigmented, and about 15% of OSSN in Asian Indians happen to have pigmentation. Do you think this is ocular surface squamous neoplasia? This is a differential diagnosis. It is an interpalpebral bulbar location, but it is away from the limbus, right? Limbus is not affected at all. OSSN is a tumor of the limbal stem cells, so it is not at the limbus. There is no corneal epithelial component. It has this pearly white configuration, but abnormal vascularity. This happened to be a large molluscum, conjunctival molluscum, which can happen generally in the eyelids. This was conjunctival. This is benign hereditary intraepithelial dyskeratosis. This is seen in triracial individuals. This looks like OSSN. Again, it is not at the limbus, slightly away from the limbus, a fleshy lesion. This was a conjunctival pyogenic granuloma. Right, so very typical lesions. This is again a conjunctival pyogenic granuloma in a situation where a pseudopterygium has been excised, and you see exuberant scar tissue that has formed in the area where pseudopterygium has been excised, and that is a conjunctival papilloma. So you should be knowing about the differential diagnosis as well. That's a pyogenic granuloma of the lateral fornix. So the morphological features are very important. Now to sum it up, the morphological features, if you have a patient with a conjunctival tumor, if it has keratin, then that has 80% sensitivity and 92% specificity to the diagnosis of OSSN. Now, apart from keratin, if it has abnormal vascular pattern, feeder vessels, and intrinsic vascularity, then that increases the sensitivity and specificity quite significantly. If you're still confused, instill a drop or just use a rose bengal strip and strain the conjunctiva with rose bengal. If there is rose bengal staining of the lesion, all these pink areas are stained with rose bengal, then your diagnostic sensitivity and specificity are extremely high. You're as good as the gold standard, that is histopathology. Summary of this slide is, if you have a conjunctival lesion which may look like pterygium, pinguicula, conjunctival scar, anything for that matter, but if it has abnormal vascularity, keratin, and it also stains with rose bengal, then you should treat it with a lot of respect and treat it like ocular surface squamous neoplasia. These are your triad of clinical signs. Right? Apart from that, if you're still confused, you can use this very important and easily available tool, anterior segment OCT. Again, it has three signs. This was described by Dr. Carol Karp. One is normal corneal epithelium is grayish and about 60-70 micron thick. When it becomes hyperplastic, that means it becomes taller, hyperreflective, it turns white, and it abruptly ends like this with a snout-like ending. So hyperplastic, hyperreflective corneal epithelium which abruptly truncates are the triad of signs of ocular surface squamous neoplasia on anterior segment OCT. So if you have any doubt at all, you can do anterior segment OCT and diagnose it. These are all situations where ASOCT has been performed, and you can actually see that it mimics the histopathology finally. So ASOCT and UBM are very good tools in diagnosing OSSN and also determining the depth of the lesion or the base of the lesion, which becomes very important. This is a corneal OSSN. This is the normal corneal thickness. In this area, cornea is splayed or it's become thicker, and there is intrinsic vascularity within the corneal stroma. So this OSSN has involved the corneal stroma already. That means that the patient will need either a penetrating keratoplasty or brachytherapy. So you can actually determine what kind of management you want to do based on ASOCT and UBM signs. The only fallacy of these imaging modalities is that if there is a lot of keratin, then that causes a shadow artifact. So you will not be able to judge the posterior extent of the lesion, although that will not interfere with your diagnosis. Now, systemic associations are also to be known. Xeroderma pigmentosum, HIV, AIDS, post-organ transplantation, immunosuppression, and palmoplantar keratoderma are the associations. And in xeroderma, you have bilateral lesions in teenagers, which are multifocal and recurrent. And even in patients who have immunosuppression, HIV positive or immunosuppression of any etiology, they have multifocal bilateral lesions. And they can also have skin papillomas, as this patient with organ transplantation has. This is a case of palmoplantar keratoderma. You can see keratoderma very clearly, and also they have abnormality of the nails as well, toenails, and have ocular surface squamous neoplasia. I'll skip the AJCC8, it is not very relevant to this audience, but I'll very quickly go to melanocytic tumors. Which conjunctival pigmented lesion would you worry about? There are a lot of conjunctival pigmented lesions. This is a very simple classification. Complexion associated melanosis, or based on the skin pigmentation, that's called CAM. It was earlier called racial melanosis, which is not a very nice term, so we have shifted the emphasis on complexion, not race, which is also not a good term anyway, but it has to be there. Primary acquired melanosis is called PAM. They also call it CMIN, that is conjunctival melanocytic intraepithelial neoplasia. Secondary acquired melanosis is called SAM, which could be actinic. That means you get yourself exposed to sunlight, you are an outdoor person, and you have conjunctival pigmentation. Or you are a farmer, you spend a lot of time outdoors, you get conjunctival pigmentation. That is actinic. Reactive. A child has vernal keratoconjunctivitis and has conjunctival pigmentation, that's reactive. Use a lot of anti-glaucoma medications or medications which have a lot of preservatives, you have reactive pigmentation. Depository, somebody is fond of using makeup around the eye and this pigmentation gets deposited in the conjunctival epithelium, that is depository. Adrenochrome containing anti-glaucoma medications such as Epitrate that were being used when we were residents can cause depository pigmentation of silver. Systemic diseases, Oguchi's disease, etc., can cause pigmentation, nevus, melanoma, and scleral pigmentation. Very quickly moving on to these pigmentations. Now, if you have a patient who has bilateral conjunctival pigmentation, both eyes there is pigmentation, you go back home and look at your parents, you'll see that all of them will have some amount of conjunctival pigmentation. Your children may have conjunctival pigmentation. That is all complexion associated melanosis. That is seen in all of us. All Asian Indians will have complexion associated melanosis. But if it is unilateral like this, as extensive as this, then you worry about it. So you don't worry about bilateral conjunctival pigmentation, but only when it is unilateral like this, you worry about it. And when it is fleshy like this, again you worry about it because it is melanoma. So whenever there is extreme amount of vascularity, blood vessels coming from all directions to feed a hungry tumor, there is a lot of vascularity, so much so that this pigmented lesion has become fleshy and it is dark charcoal black or dark brown, then it is a conjunctival melanoma. Now, these are typical features of complexion associated melanosis. It has this cobblestone kind of an architecture, some amount of symmetry. It may not be exactly mirror image symmetry, but there is some amount of symmetry in terms of the extent of pigmentation. Then it is complexion associated melanosis. You simply observe it. Any amount of gross asymmetry is primary acquired melanosis. This is not complexion associated melanosis. This is primary acquired melanosis because there is asymmetry. So primary acquired melanosis occurs in unilateral situations, middle-aged individuals, flat, there are no cysts, and it is peppery. So basically it looks like as if there is a dusting of pepper on top of the sclera. So whenever there is asymmetry, you have to rule out primary acquired melanosis, and in such situations we should look at the fornix as well because it can extend to the conjunctival fornix. So peppery architecture, unilaterality, involvement of the conjunctiva beyond the interpalpebral vulva conjunctiva into the fornicial conjunctiva, all these are features of primary acquired melanosis. Very clear peppery architecture. Why is primary acquired melanosis important? Because about 10 to 30% of them convert to melanoma. And the most common origin of melanoma is not nevus, but primary acquired melanosis. When it is small, because each clock hour adds a risk of it being melanoma. So if it is small, less than 1 clock hours, you simply watch. You do nothing about it. You simply observe the patient. If it is more than 1 clock hour, say in this patient there is about 6 to 7 clock hours of involvement, the risk is 12 times high, 1.7 it's the odds ratio per clock hour of involvement, then you treat. How do you treat it? You excise all the involved conjunctiva and do cryotherapy to the excision edge. Or if it is very extensive, then you do map biopsy of the conjunctiva, find out which areas have atypical nature and excise only that, or use topical mitomycin C. These are the treatment options. These are all various extents of PAM which you should be looking for. Very extensive PAM. And whenever PAM is not treated or it is ignored, it will very soon develop into a melanoma. The incidence of conjunctival melanoma, 75% of which is contributed by PAM. Only 20% are de novo and only 5% arise from a pre-existing nevus. So this is a very stark data that you have in front of you. This is true published data. This is a patient who has a fornicial PAM and this nodule is a melanoma that is arising from it. This patient has an inferior fornicial PAM and that nodule is a melanoma. So PAM can definitely give rise to melanoma. This is a patient with extensive PAM and you can see popping out melanoma there. This is a different way of classifying PAM which I will not go into. Alright, coming to a very common lesion, conjunctival nevus. I have 4 pictures in front of you. Can any one of you guess which one is not a nevus? Is it easy or is it difficult? Let's just name it A, B, C, D. Now which one is not a nevus? Well, we can keep guessing. Most of us will be right when you guess it. But if this patient is sitting on your chair on Monday morning when you all go back to the clinics after AIOC and you have to take a decision as to which one is a nevus and which one is not a nevus and you have to commit to a treatment, how do you do that? Well, we have a clinical checklist, and clinical checklist is very simple. If it is located in the interpalpebral bulbar area, if it has variable pigmentation starting from tan brown to dark brown, there is no corneal epithelial invasion, it respects the limbus, stops just short of it. It has no episcleral fixation. If you move it with a wet cotton-tipped applicator on the sclera, it moves very nicely. No intrinsic vascularity. Feeder vessels are bound to be there, but there is no blood vessel within the lesion that you can see. The lacy network of blood vessels is absent. And more importantly, presence of microcysts. If you go back to this, you may argue with me saying that, oh, this has corneal epithelial invasion. No, it is like a fat belly hanging onto the belt, hanging beyond the belt. It is like a huge nevus which is overhanging the cornea. If it were to have epithelial invasion, it would be ragged edges like this. It would carry pigmentation and vascularity along with it. This one does not have interpalpebral vulvar location, but it has variable pigmentation and it is respecting the limbus. So all these are nevi of various types, but all of them are definitely nevi. All of them have been excised and I have the histopathology to back me up. So these are definitely nevi. There's no doubt about it. Last bit I was telling you about was the microcysts. These are the microcysts. In pigmented eyes, microcysts can sometimes be masked by the pigmentation. That is why you can again depend on anterior segment OCT and UBM to see if they have microcysts or not. This patient has microcysts. This one has macrocysts. Presence of microcysts and macrocysts confirms the diagnosis of a nevus. Nevi are spongy. They do have microcysts and macrocysts. Melanoma is solid. It does not have any of that. This is just some data to back up what I said. This is data from the literature. Most of the nevi occur in the bulbar conjunctiva. Most of the nevi occur in the temporal bulbar conjunctiva. This is from data. Now, how do you use all this that you just learned in a clinical situation like this? This 11-year-old child of very aggressive physician parents is brought to you with a fleshy pink conjunctival lesion, which they have noticed only 2 weeks ago. They have read the literature, they are doctors, and they have found that, oh, this has a blood vessel feeding it, so it has to be a malignant lesion. They are worried. So how do you commit to them? How do you go about it? 11-year-old child, for the first time, parents have noticed it. And it has unfortunately involved the corneal epithelium just by 0.1 millimeter. Right? So simply do a test. Right? OCT shows microcyst, so it's an amelanotic nevus. Preteen children do have amelanotic nevus, and as they go through their teenage years, it acquires pigmentation, it becomes classic nevus. So use your imaging very effectively to diagnose that it is an amelanotic nevus. Nevi can also be bilateral, as you see here. Now, cysts are seen in a nevi in about 2/3 of patients. Cysts are clinically seen if it is less pigmented, but otherwise it is seen on imaging. Cysts are not pathognomic of a nevus. Cysts can be present in lymphangiectasia and also mucoepidermoid squamous cell carcinoma. It should be very clear what you see. And when a cystic lesion turns solid, that means that it is turning into a melanoma. This nevus always had cysts, but one portion turned solid, and that was a new melanoma that has grown out of a pre-existing nevus. We know that 5% of nevi turn into melanoma. This was a teenage child. When I saw him first, he was absolutely fine. He had a supranasal nevus, and we followed up for 5 years, and then he went into college to a different city. After 6 years, he came back with a new growth from a pre-existing nevus, which was much darker, fleshy with subconjunctival hemorrhage. And it also had very aggressive vascularity. This was the nevus that he always had, and this was a new growth arising out of a nevus. Just to show you how effective imaging is, we did his imaging and also excised it and did histopathology. This was the solid component of the lesion. That's the cystic component of the lesion. Cystic component is nevus, solid component is melanoma, and that is the zone of transition of the nevus into a melanoma. So what you see on imaging mimics histopathology, and that's why imaging is very important in a pigmented conjunctival lesion as well, as important as it is in epithelial lesions. Now, we already showed melanomas and all that palpable conjunctival involvement is also known, so you should look for that as well, and that's a nodular variant of melanoma. This looks very aggressive like a melanoma, but it is actually a balloon cell nevus. You can see a white sclera. There is no vascularity at all, although it looks clinically very dangerous. It's just a balloon cell nevus. See how dangerous it looks, but it's simply a nevus. This is also pigmented, but you spot bits of keratin here and corneal epithelial invasion, so it's a pigmented squamous cell carcinoma. This is some of the differential diagnosis for a pigmented conjunctival lesion. This is a true story. This young lady came with her fiancé asking for her eyes to be made white because she has a nevus and they don't like it. Both of them didn't like it. Do you see anything abnormal here? She has a steamy cornea and her pressure was 38. And she has an iris lesion as well. So this was an extraocular extension of a ring melanoma of the iris and trabecular meshwork. She had a white eye because we had to enucleate her. She had an extensive melanoma. And finally, she had a prosthetic nice white eye. So you can easily get fooled by a small conjunctival lesion and miss what is underlying. So you have to do gonioscopy in any patient who has a large scleral nodule or a pigmentation. That's a patient with pigmentary disorder where the melanoma can be amelanotic. And that's not melanoma, that is neither a melanoma nor a nevus, that is episcleral or scleral pigmentation in a patient with nevus of Ota. Right? So ocular melanocytosis can look like a nevus, but that is scleral pigmentation where you should be looking for uveal melanoma and not anything else. So we started about 10 minutes late, so I think I have about at least 5 minutes to 7 minutes to complete the management. I'll very quickly go through the management. Management, I think, is very simple. If you learned how to diagnose a lesion, management becomes very simple. Now, when we consider or talk about management, we always begin with topical therapy. For ocular surface squamous neoplasia, topical therapy is the easiest to do. It is very extensively practiced, but the criteria is that you should have a clear clinical diagnosis. You cannot do a biopsy just to confirm a diagnosis. So whatever I've said in the last half an hour, 20 minutes, is the background on which you can start your treatment. If you haven't registered that earlier part, then you obviously will not go ahead with the management. These are the drugs that are used. Chemotherapeutic drugs are mitomycin and 5-fluorouracil. And immunotherapy that is used is interferon. These are the chemotherapeutic agents and that is the immunotherapeutic agent. Now the dose that is used, you often keep asking. In mitomycin, it is 0.04% or 4 milligram per 0.4 milligram per ml. QID, 1 week on, 1 week off is one protocol. The second protocol is rule of 4, 4 times a day, 4 days a week for 4 weeks. That is one cycle, after which you give a gap of 2 cycles. So 2 weeks. So there are 2 rules in mitomycin, 1 week on and 1 week off, or 4 times a day, 4 days a week for 4 weeks. And then you give a gap of 2 weeks. In 5-fluorouracil, it is 1% drop. It comes as 5%, so you dilute it, make it 1%. QID, 1 week on and 3 weeks off. That is one cycle. In interferon alpha 2b, it is 1 million international units per ml. It comes as 3 or 5 million international units. You simply dilute it using any tier substitute and make it 1 million international unit and dispense it. Patient uses QID, never stops it till you tell the patient to stop it. Minimal response time. So when do you assess the response after starting this treatment? For mitomycin, it is 1 cycle. When the patient comes back to you after completing 1 cycle, you compare the photographs. That is the best way to assess. You take pictures, nice pictures, not on your mobile, but good slit lamp pictures, and compare head-to-head photographs. And if there is good response, then you continue. If there is no response, you have to change your strategy. In 5-fluorouracil, it is again 1 cycle, and interferon, it is 6 weeks. So if there is no response within this minimal response time, you either shift to surgery or shift to any of the other drugs. If you begin with 5-FU, you can shift to interferon. If you begin with interferon, you can shift to 5-FU. If you begin with 5-FU, you can shift to mitomycin. So some tumors are not responsive to one drug, so you have an argument to shift to another drug. But don't use 2 drugs at the same time. That is not acceptable, because there is huge amount of corneal epithelial toxicity. Maximum duration. This is a question that is often asked. How long can we use it without causing complications to corneal epithelium and the limbal stem cells? In mitomycin, it is 3 months. It is most toxic to corneal limbal stem cell and also corneal epithelium. In case of 5-fluorouracil, it is 6 months, and in interferon, it can be indefinite. You can continue it forever. How is interferon used? It's used in 3 modalities. Immunotherapy is to completely eradicate the tumor. Immunoreduction to reduce the tumor size and then do surgery. Immunomodulation is to enhance the local immunity of the ocular surface so that the patient does not have local tumor recurrence. So small tumors like this can be completely cured with topical therapy. This is called immunotherapy or chemotherapy, where the intent is to completely eradicate the tumor. You don't intend to do surgery. Your intention is to completely eradicate the tumor. Also, tumors which are recurrent. This was a small tumor in the background of prior surgery. Small recurrent tumor completely eradicated with topical therapy. Corneal ocular surface squamous neoplasia is a specific indication for topical therapy. In this patient, this is my favorite slide. I would like to demonstrate one important finding here. This is an area where my cornea specialist colleague had done a biopsy before he sent the patient over to me. Rest of the tumor was taken care of by topical therapy. 3 years later, you can see exactly in the same area where a very competent cornea surgeon had done a biopsy, there is a small corneal scar. Which means that if you were to do primary surgery in this patient, the ocular surface of the cornea in the pupillary axis might have had a small scar, thus reducing the visual acuity of the patient. So there is an indication in patients with corneal AIOC to do topical therapy, or in patients who have a tumor right at the corneal graft host junction. So this is a patient who has xeroderma pigmentosum, other eye is blind. This is his 3rd graft, and on top of that he has a OSSN at the graft host junction, where if you were to do surgery, you may tip the balance in favor of a graft rejection or a graft failure. There you use topical therapy. You can see how cornea has become very clear following topical therapy. Or in patients who have more than 6 clock hours of limbal involvement, where if you were to do primary surgery, there would be a possibility of limbal stem cell deficiency, where you have a scarless healing with topical therapy. That's the 3rd indication. And the 4th indication is diffuse OSSN, where almost the entire ocular surface is involved. If you have a tall lesion like this, I would prefer surgery. But if I have a flat lesion like this, I would prefer topical therapy. And this took about 6 months of patient use of topical interferon, but there is no need for surgery here at all. So you should choose your cases. If you have a patient where there is a tall lesion like this, then possibly it is not a good case for topical therapy. You should possibly do primary surgery. Immunoreduction is a principle where you reduce the size of the tumor before you do surgery. Now this patient has an extensive tumor, very large tumor, which is flat. Of course, you can excise it. But upon immunotherapy, what has happened is that the tumor has become much smaller. And why does that happen? If you consider this as the epicenter of the tumor, that is limbus, that would have the invasive squamous cell carcinoma component, or around it. Around that would be a zone of carcinoma in situ, severe, moderate and mild dysplasia that is followed by normal conjunctiva. So what topical therapy does is it takes care of all the dysplasia and carcinoma in situ, and finally what is left is invasive squamous cell carcinoma component, which is refractory to topical therapy, that you will excise. You don't excise the entire ocular surface just for the sake of excising it. So if you have a critical situation where vision is very important for the patient, other eye may have been blind or having amblyopia, etc., there you want to have minimal surgery. That's the reason why you do immunoreduction, and finally immunomodulation in patients who are predisposed to these tumors. So case selection is very important for topical therapy. Whenever you have a diagnosis in doubt or whenever you have a scleral invasion, you don't want to use topical therapy at all. Quickly about surgery. Surgery would mean excision with edge as well as base clearance. Edge is very easy to detect. You see the patient on slit lamp, stain the tumor with rose bengal, you have the entire edge visible, beyond which you go 4 millimeter and you're done. But what about the base? Base has to be assessed on imaging sometimes, because on slit lamp you may not be able to assess the base. So you have to do imaging to see how deep the tumor is, and then you excise it. That is how you deal with the base. This case I earlier showed. that this involves a corneal stroma already, so excision is not the cure for this patient, and we have a habit of making these large conjunctival diagrams like the retina diagram that you have seen to map out the entire extent of the tumor, so excision becomes very easy. I'll skip the surgery. Results are very evident, results are very good. In fact, surgery is one of the best options. But there are some situations which are beyond surgery. Patients who have scleral invasion, earlier we would do enucleation, extended enucleation or orbital exentration. Now we can rescue these patients with plaque brachytherapy. Extensive scleral invasion, suppose this is the eye and this is the scleral invasion. What do? You do a flush excision along the sclera without disturbing the sclera or doing sclerectomy. On top of the bed of the tumor, you apply brachytherapy, which is either ruthenium or iodine. And you can see results like this. This is secondary plaque brachytherapy. So what we do is, we excise this tumor without any lamellar scleral dissection. And on the bed, we apply plaque for the duration of exposure, and then that is the kind of results you get. It's only 2 millimeter thickness that you're treating, and it is very safe. Radiation is very safe. You get tectonically strong sclera back. There is no perforation. Risk of perforation is almost zero. But when you have a stromal melt already, like this patient has a stromal melt, can you do surgery in this patient without causing corneal perforation or scleral perforation? You cannot. There you use primary plaque brachytherapy. You apply plaque right on top of this necrotic melting tumor, and again you will get good results in a majority of situations. So either you excise it and put the plaque, or without excising it, if you can have that kind of a dosimetry support by your radiation oncologist, you can put the plaque. Results are the same. This is a patient with melanoma with scleral invasion that completely gone with plaque brachytherapy. So plaque has come as a boon to us for ocular surface tumors. This is an extensive tumor in a Kashmiri patient who had 3 times excision elsewhere, and he wants vision. He has 6/6 and 6 vision already, which he wants to save. That is the extent of the tumor that we have, melanoma with unfortunate intraocular extension and ciliary body invasion. These are the ciliary processes that you see. We could have easily exenterated him, but he wanted eye salvage. I'll skip the video again. Again, we use plaque brachytherapy, but the rotational technique where we treated every bit of the surface of the eye with brachytherapy after excision, and he looks good after 3 years of follow-up. So brachytherapy has about 90% success, which has been recently published in British Journal of Ophthalmology. Even in desperate situations like this, where it's scleral invasion in a young individual like this who wants eye salvage with choroidal detachment, retinal detachment, you can see the extent of the tumor with ciliary body invasion. Our radiation oncologist can design stereotactic radiation for him with chemo-augmented, cisplatin-augmented radiation, and you can see nice results. Choroidal detachment, retinal detachment have settled, and his intrascleral and scleral invasion have gone, and his ciliary body extension is also gone. So there are very good treatments that are available for squamous cell carcinoma currently, and only these desperate situations need orbital exentration. So I think our time has ended much beyond what is permitted. Thank you so much. Yeah. Where do you get the plaque? BARC, Mumbai. We have made a plaque, Indian plaque. So it's made by BARC, Bhabha Atomic Research Center, and they can supply it if your institute is radiation approved. That's right. That depends on the radiation dosimetry. We have a software which calculates the dose and the duration, and based on which we do. It's about 48 to 72 hours for conjunctival tumors maximum, even 24 hours sometimes. They are involved, but the majority of work is done by us. They are theoretically there, but practical work is all yours. Brachytherapy source used to be 10,000 US dollars, but the one that we have made is 50,000 Indian rupees. So it's like 5% of the cost. We have 2 sizes. One is 12 millimeter in diameter, another is 16 by 20. We have other sizes also in the making. There's a pediatric plaque with 8 millimeter diameter that is already made. We are making other designs as well. So size is not a limitation. You can use the same plaque in different locations. You can combine 2 plaques. So size is never a limitation. You need to first get your institute approved for radiation. Yeah. Then you can contact. No, it is, radiation is incorporated within the plaque. It's ruthenium. Ruthenium is a radioactive source. They are there for safety, and the radiation physicist calculates the dosimetry for you.
Because the plug actually radiates by itself, and we are going to stitch the plug onto the sclera.
Correct.
And that's it. After that, we don't need to do
so
anything.
these are government rules, safety rules. Government treats ants and elephants by the same yardstick. Ruthenium is least harmful. I've been using ruthenium since 2004, that's 20 years. And I don't have any radiation exposure, documented radiation exposure, because I have to carry the TLD badge in my pocket and my wrist all the time. My radiation exposure is negligible so far. Every surgery we measure our radiation exposure. It is negligible. All right. So, but then the rules are the same. You have to have a radiation physicist and a radiation oncologist. Anita knows about it. She has set it up in her hospital. It is very, very stringent. Very stringent.
So do they send it autoclaved, sir, or do we
have to autoclave every time.
Get it, autoclave it, and then use it.
Yes.
It comes with the holes, is it, for us to switch
Yes.
to the?
It comes with everything.
Okay. Thank you, sir. Thank you.